Hello folks, in this video we are going to talk about the Protocol S of the DRCR-NET. The Protocol S aimed to investigate whether ranibizumab was non-inferior in the treatment of PDR compared to the standard of care, which is PRP laser. For this study, 305 patients with diabetes were randomized into two groups. The first group involved the standard of care with a PRP laser from 12 to 1600 shots of laser single shot or 1800 shots multi-spot of laser within 8 weeks period. Patients in this group were allowed to undergo intravitreal ranibizumab if the patients developed diabetic macroedema. The second group involved treatment with ranibizumab monthly for 16 weeks. After 16 weeks, patients could have deferred injections, or no injections, if they were stable or inactive for at least two visits. The dose of ranibizumab was 0.5 milligrams because at the beginning of the study the 0.3 milligram ranibizumab was not FDA approved yet. Patients were followed up to 5 years and there was an interim analysis, important one, at 2 years. Let's talk about the results. In both groups, the risk of severe visual loss was similar, about 6%. Final mean visual acuity in both groups were also the same. Visual field loss was lower in the ranibizumab group at year 2. However, at year 5, visual loss was similar in both groups. Let's talk about diabetic macroedema. The risk of developing diabetic macroedema was lower naturally in the ranibizumab group. The number of injections was lower naturally in the PRP group. About 50% of the patients developed vitreous hemorrhage in both groups. In the ranibizumab group, there were a few advantages. The risk of retinal detachment or the need of vitrectomy was similar. It was lower in the ranibizumab group. So let's talk about some aspects and conclusions of the Protocol S. It's very interesting that at year 5, the visual loss was similar in both groups. That's probably because the injection itself caused increase in intraocular pressure, and that increase in the pressure might damage the retinal ganglion cell and fiber layers, which can cause visual field defects. It's very interesting as well that the need of vitrectomy and the rate of detachment was lower in the ranibizumab group. We must keep in mind that for patients with a risk of loss to follow-up, ranibizumab group monthly with a monthly follow-up is much more dangerous than PRP laser. On the other hand, some patients needed additional laser after the initial 1 to 3 sessions of PRP. So the Protocol S provided important information that ranibizumab is non-inferior to laser in the treatment of proliferative diabetic retinopathy. I hope you enjoyed this video. See you next time.